Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. Now, what's going on in this chest x-ray? Are you able to tell that there's some sort of pneumonia happening? You should consider radiology if you can see that. Anyhow, we're going to be discussing pulmonary infections pathology. This is covered in your book, Medical School Pathology and Step 1 Review. You can scan the QR code to get to the website with all the updated material. Now let's jump right into this, okay? Because this is a big deal. You will see it. Let's start off with talking about pulmonary infections. What is that exactly? Well, it's pretty simple. Pulmonary infections are diseases of the lungs due to microorganisms. Pulmonary infections include pneumonia and tuberculosis. These show up classically at your level. So what is pneumonia? Well, pneumonia is a parenchymal lung infection. Pneumonia may occur when the body's natural defenses are weakened. For example, they could be weakened due to an impaired cough reflex or damage to the mucociliary escalator, as we can see in cystic fibrosis. What's that mutation, by the way? Typically, the most common one. Delta F508, right? Mucus plugging is associated with pneumonia. Right. So be aware of this. Symptoms of pneumonia may include fever, chills, a productive cough with that yellow-green pus or rusty-colored. Yeah, I don't like that. Tachypnea or pleuritic chest discomfort. Medical and lab findings of pneumonia include diminished breath sounds, dullness to percussion, an elevated leukocyte count, chest x-ray that's clearly showing a pneumonia process, and sputum, gram stain, and culture that may show the bacterial etiology of the pneumonia. Blood cultures are even sometimes used to make the diagnosis of pneumonia. Regarding pneumonia, there are 3 patterns that you must know. That's lobar pneumonia, bronchopneumonia, and interstitial pneumonia. Now, all you future radiologists out there, I'm sure you can see the lesion. But even if you're not going into radiology, I'm pretty sure you can see the lesion on this. So point it out if you can see it. I'm proud of you. That's why I'm so happy. Keep doing a great job. So we're going to make sure you know about lobar pneumonia, okay? Lobar pneumonia is characterized by the consolidation of a whole lung lobe, as we can see here, right? Lobar pneumonia is typically caused by bacteria, which include Streptococcus pneumonia, more commonly, and Klebsiella pneumonia, right? The typical gross lobar pneumonia phases include congestion, resulting from the edema and clogged vessels, followed by exudate and neutrophils and hemorrhage caused by the red hepatization, right, the second phase, which gives the typically spongy lung a solid consistency by filling the alveolar air spaces. The last phase is the gray hepatization as a result of red blood cell breakdown in the exudate. Now again, these are gross findings, right? This is pathology at the physical level. So it's highly unlikely that you will ever see this in real life unless you're going into pathology of the autopsy sorts or working at the medical examiner. But for your purposes and testing purposes, just remember the three phases. It starts off as edema causing congestion, right? Then the inflammatory cells come, specifically those neutrophils, right? Causing this exudate and red hepatization. And the last stage is gray hepatization as things start breaking down into the exudate, okay? So let's talk about lobar pneumonia some more, right? Now, here we have an H&E stain, which you may see, even at your level, showing diffuse sheets of inflammatory cells. And if you look closely, it looks a bit gritty, right? We have some scattered red blood cells in there. But now let's talk about another commonly tested condition, bronchopneumonia. Now, this condition is characterized by patchy, sporadic consolidation. And it's concentrated on the bronchioles, as you can see here in this image, right? With this bronchopneumonia showing the neutrophils actually filling up a bronchiole. Bronchopneumonia is frequently bilateral and multifocal. It's caused by different bacterial species. Okay? Now, let's talk about interstitial pneumonia. Interstitial pneumonia is also known as atypical pneumonia. To the right, we can see a micrograph of interstitial pneumonia from a patient who underwent an autopsy. In regards to interstitial pneumonia, there's a diffuse interstitial infiltrates that are the defining features of this condition. Interstitial pneumonia typically presents with only a few minor upper respiratory symptoms. So they might have a little cough or a little fever, hence the atypical presentation. And interstitial pneumonia is typically caused by bacteria or viruses. And here we can see the various radiology and histopathology correlates for several cases of pneumonia. And here we can see a lung grossly that's been impacted by interstitial pneumonia. And now at the microscopic level, we can see some histologic features of interstitial pneumonia. Note the diffuse alveolar damage that is present as well. And in this imaging of H&E specimens, we can see the tissue from a 45-year-old male who was diagnosed with interstitial pneumonia. Now let's move on to another important condition which you will definitely be asked about for sure, aspiration pneumonia. Now aspiration pneumonia is seen in individuals who are at risk for aspiration, such as alcoholics and people who are unconscious. The oropharynx anaerobic bacteria such as Bacteroides or Fusobacterium and Peptococcus are typical causes of aspiration pneumonia. Aspiration pneumonia classically leads to a right lower lobe abscess. Right. And this is due to the angle of the bronchus. Just keep in mind that in real life, it may also present in different lobes. On testing purposes, or for testing purposes though, it's usually on the right. They want to make sure you understand the anatomy, is what the people are trying to get at for the most part. So compared to the left, the right main stem bronchus branches anatomically at a less sharp angle. Now let's move on to another highly important topic, TB, right? You know what TB stands for? Tuberculosis, right? As a result of first-time exposure to aerosolized Mycobacterium tuberculosis, the development of primary tuberculosis may ensue. Tuberculosis results in the hilar lymph nodes undergoing fibrosis and calcification to produce a Ghon complex, right? You've heard that before, I'm sure you have. A Ghon complex, as well as localized casating necrosis, right? Classic casating necrosis of the lung. Although primary tuberculosis usually has no symptoms, it does result typically in a positive purified protein derivative test, a PPD test. When Mycobacterium tuberculosis reactivates, secondary tuberculosis develops. Reactivation of Mycobacterium tuberculosis is frequently caused by AIDS, although it can be caused by other immune-compromising issues such as disease or advanced age or immunosuppression, etc. Tuberculosis usually occurs at the lung's apex due to the high oxygen tension in that region of the lungs. Tuberculosis creates a cavitary foci of caseous necrosis and has the potential to cause tuberculosis affecting the bronchospaces, known as tuberculosis bronchopneumonia or miliary pulmonary tuberculosis. Symptoms of tuberculosis include fever, weight loss, night sweats, coughing, and hemoptysis. Now, if you saw these findings in a, let's say, female patient in her late 20s, right? What should be at the top of your differential, right? Let's say she also has cervical adenopathy. I'll give you a clue. The cells that you would see on histology would have owl eyes, right? Hodgkin's lymphoma, right? Make sure you have Hodgkin's lymphoma on the differential and read into what you need to read into to make sure you can tease out what the actual disease is, okay? But in the case of TB, be aware of fever, weight loss, night sweats, and cough with hemoptysis. The histology of tuberculosis shows caseating granulomas and positive acid-fast bacilli with the AFB stain. Common sites for systemic dissemination of tuberculosis include the meninges, cervical lymph nodes, the kidneys, and the lumbar vertebrae, which goes colloquially by the eponym of Pot disease. And with that, you've completed another lecture. You're making strides to ensure your success. And that's why I believe in you, because you're rocking out. You're doing so well. I'm proud of you. Keep up the studying. Make sure you understand everything, because it will show up. If you have any questions, comments, or concerns, let me know. And I'm rooting for you. See you later.